everyone, welcome back. Today we're going to be talking about hepatitis, which is an amazing but yet complicated thing that we all have to learn during 3B. So let's start off, Simran, with what is hepatitis?
Yep, thank you, Shao. So hepatitis is basically inflammation of a liver tissue. This can be temporary, which we call acute hepatitis, or it can be long-term, which is termed chronic hepatitis. In terms of the actual timeline, acute hepatitis is inflammation of the liver that lasts less than 6 months, and chronic is inflammation of the liver that lasts for more than 6 months. In terms of the different causes, there are many causes of hepatitis. The most common cause is viral causes, and that's going to be our focus for today. But there are also other causes to keep in mind when you think about hepatitis, and that includes other infections like parasitic or bacterial infections, autoimmune hepatitis, metabolic stuff, so alcohol-related hepatitis, any drug-induced hepatitis, most commonly would be like paracetamol, statins, steroids like the oral contraceptive pill. And there's also genetic causes as well. So alpha-1 antitrypsin deficiency, hemochromatosis, which is when there's too much iron in the body, and Wilson's disease, which is characterized by a lot of copper in the body, as well as ischemic related stuff. So any shock to the liver that's associated with heart failure. In terms of how inflammation of the liver happens in terms of viral hepatitis, what happens is the virus enters the body and travels to the liver. Once it enters the liver, it attaches to healthy liver cells and multiplies. And this replication process triggers the body's immune system, which will then result in inflammation and then lead to acute hepatitis. So the actual hepatitis or the inflammation is not due to the virus, it's due to the immune response to the virus.
So in terms of viral hepatitis, there are 5 types that we need to learn. And luckily they've been named A, B, C, D, and E. So this is best represented via a table, and that's basically what I'm going to do for you today. I'm going to read off a table, and what we need to understand is basically the transmission, the prevention, the time course, whether it's self-limiting, and the complications of each viral hepatitis. So let's talk about transmission. The best way to group hepatitises is via their transmission. So you have hepatitis A and hepatitis E, which are mainly transmitted via contaminated food and water, and these are called fecal-oral transmission. And then you have hepatitis B, C, and D, which are transmitted via infected blood as well as bodily fluids. Now in Australia, hepatitis C is most commonly passed via needle sharing. So IV drug users are particularly susceptible to hepatitis C, whereas hepatitis B is not really something that's still being communicated via the community. It tends to be people who come back from maybe Vietnam or maybe other countries where hepatitis B is endemic, and perhaps they either had high-risk activities such as unprotected sex, or perhaps they decided to have IV drug use in those countries as well. But something to think about is worldwide, so internationally, hepatitis B is usually transmitted from mum to bub and that happens through birth. So the second point is which one is preventable via immunization. So you and I would have both gone through immunizations in order to enter the health course. So hepatitis A and hepatitis B is the vaccinations that you would have gotten, and it's good to remember because hepatitis A and hepatitis B are what's available on the market. There's something that I almost forgot to talk to you about, and that's the transmission of hepatitis D. So hepatitis D is only going to be, only infect those who already have hepatitis B. So in terms of prevention, if you don't get hepatitis B, you won't get hepatitis D. So indirectly, if you have the vaccination, you're also protected from hepatitis D. In terms of time course, well, we can go back to our two groups. Hepatitis A and E are usually acute, so they last less than 6 months, whereas B, C, and D are more likely to be acute or chronic. Is it self-limiting? Again, hepatitis A and E are self-limiting. Hepatitis B, C, and D are a little bit different. Hepatitis B is usually self-limiting, but there are about 5% that can progress to chronic hepatitis, whereas hepatitis C is the opposite. Some of them are acute, but most of them lead to this chronic grumbling type disease. What do I mean by that? That's hepatitis C is usually the asymptomatic hepatitis, except it still causes inflammation and your body has a really tough time getting rid of it. And it tends to cause a lot of very minimal damage over a long period of time, and it can lead to chronic hepatitis and then liver cirrhosis. So this is really important because the complication that we're all really looking out for as clinicians is fulminant hepatitis. So that's sort of the hepatitis that causes liver failure. So this happens in A, B, D, and E. So let me say that again, A, B, D, and E. Basically, these hepatitises can sort of unfortunately cause liver failure during their pathology and their pathological presentation.
Right. So, in terms of the actual history, so you have a patient who comes in. Usually, the common presentation for someone who has hepatitis is right upper quadrant pain, so any abdominal pain, jaundice, so yellowing of the eyes or their skin. They might just have nausea, vomiting. Those are the basic presentations. And then there's associated fever, fatigue, loss of appetite, weight loss, diarrhea, and some can also present with joint pain. It's also important to keep in mind that, as Xiao mentioned with hepatitis C, that there can be a lot of cases that are just asymptomatic. So many patients who do come in or come into general practice, they may also be asymptomatic and they may never be detected. When you actually do suspect someone with hepatitis, when you suspect that someone has hepatitis, there are some risk factors you want to be screening for. So it's really important to make sure that you have a good travel history and a sexual history. So when you're having a chat with a patient, you want to ask them, have you traveled anywhere recently? And when you did travel, did you get any vaccinations before traveling? Did you eat street food or did you have unfiltered water during your travel? Also during your travel, did you have any unprotected sex or use any IV drugs? And with the sexual history, you want to ask about, their partners, whether they have sex with men, women, or both, what kind of practices they have, so whether they have anal sex, oral sex, if they use any protection, and how regularly they use protection. So some may use, for instance, condoms 50% of the times. Others may use it less than 50% and more, and others may use it for more than 50%. So it's important to get an idea of their protection. If they've ever been diagnosed with any STIs in the past, and if there's any chance that they could be pregnant, or if they've been using any sort of contraception to prevent pregnancy. Other things you also want to ask or consider is whether it's an Indigenous Australian, because they're at an increased risk of hepatitis as well. So that's the basic structure for your history, and those are things you want to be thinking about when you suspect hepatitis. Once you've taken a good history and you examine the patient, some patients can have jaundice. They can have abdominal tenderness in the right upper quadrant. There might be some lymphadenopathy or enlargement of the liver and the spleen, which is called hepatosplenomegaly. In cases where patients have acute liver failure, they can also present with confusion as well. So in the situation where you've got a good history on examination and it seems to be likely that the patient has hepatitis, you want to do some investigations to confirm that suspicion and also determine what kind of hepatitis they have. So to actually confirm whether the patient has hepatitis, you want to perform LFTs, which is a blood test, and the results will basically show elevated AST and ALT, which are markers of liver injury. You can also order serology, so viral hepatitis serology for hepatitis A, B, C, D, and E. And based on the results of that, it can tell you which kind of hepatitis they have. Given the fact that the serology is actually quite confusing, and it's quite important that we cover it in detail. So we'll go through that in another episode in detail.
Thanks, Simran. So I'm here to talk to you now about the management of hepatitis. So going back to those grouped, how we group hepatitises, A and E, which are the fecal oral transmitted hepatitises, are self-limiting. You may decide that you want to admit them into hospital just due to the fact that they are looking quite sick, but most of the time you're just giving them supportive therapy. So if their blood pressure is low, give them some blood pressure support. If they've got a fever, give them antipyretics as needed. The exception, however, is if they're immunocompromised. So immunocompromised patients may have trouble trying to get rid of these viruses, so you can give them antiviral therapy such as ribavirin, just to prevent them from progressing to chronic hepatitis, which can happen in people who are immunocompromised. Hepatitis B, C, and D are sort of a different ballgame. So hepatitis B, unfortunately, is not curable, and the management can, especially the medical management, can be a little bit confusing. So one thing to note is that not everyone with hepatitis B will be taking medications. Because the medication is mainly to prevent progression to chronic liver disease, you basically only want to give them medication to prevent liver damage. And liver damage tends to happen when the hepatitis B virus is active. So basically what happens is the clinician will perform LFTs every 6 months and a serum hepatitis B virus DNA every 12 months to check whether the hep B virus is active or not. If it is active, then we do treat them with antiviral therapy, but if they're not active, then you'll just perform the tests again after 6 months or 12 months, depending on which serum investigation you're using. So there is an exception again. Basically, anyone with liver cirrhosis should be on antiviral therapies for the rest of their life. And then in terms of hepatitis D, unfortunately, hepatitis D is not curable. Usually the interventions and management is all driven by a specialist. Yes, there is some evidence that PEG interferon can dampen down the activity. However, this virus, hepatitis D, does unfortunately have the poorest prognosis. In terms of hepatitis C, well, hepatitis C is kind of the new exciting world of hepatitises. It has recently become curable, and according to ETG, new direct-acting antivirals have shown to be effective in 95% of cases. So this is really exciting news, and hopefully we'll keep hearing all these improvements in not just hepatitis C, but as well as hepatitis B and D. Now, because these are transmissible diseases, I think another thing that you would like to think about as a clinician is basically prevention of transmission. So for hepatitis B, C, and D, especially if they have the chronic virus, it's also really important to educate your patient about how it is spreaded and ways in which they can prevent it to spread from another person. So in this case, in terms of hepatitis C, like I said before, in Australia, it's mainly transmitted via needle sharing. So perhaps it's going to your local hospital pharmacy and ensuring that everyone uses clean and new needles. If you can stop them from taking IV drug use, that would be the best, but if you can't, then you can use those programs. Other ways that you can also prevent transmission to another person is using safe sex practices, so using condoms, and ensuring that they do tell other people that they do have hepatitis B or D before with anyone that they might have intercourse with, because that might mean that they can seek help if they are at a risk of an exposure. All right. Apart from management, other things that we should also think about is prevention. So this is just population prevention, aka vaccines. So hepatitis B vaccine is available to the population. Ideally, all Australians, if they consent to it, should be vaccinated against hepatitis B. So hepatitis B is given at birth and repeated again at 4 and 6 months. And hopefully with those 3 boosters, you're able to have lifelong protection. Hepatitis A, on the other hand, is not given to the population. It's only for at-risk groups. So these include health workers, childcare workers, sewage workers, men who have sex with men, people with chronic liver diseases, people who are receiving blood products, as well as travelers to Hep A endemic countries. So just now I was just talking about exposure. So what do you do when someone has been exposed? So this is called exposure or rescue management. So in the case that you are either A, being exposed to Hep B blood due to a needle stick injury, or perhaps your patient or yourself might have been exposed to a person with hepatitis B through unprotected sex, then the management at the moment, the protocol, is to receive Hep B immunoglobulin within 72 hours of exposure, and also a dose of hepatitis B vaccine within 7 days of the exposure. And the idea is get it in quick, get it in fast, because you're going to have a better, it's the immunoglobulin and vaccine is going to have a better chance of working the quicker you get it into your body. All right, and then just lastly, talking about the complications. So what are the complications of hepatitis? So again, we're all looking for fulminant hepatitis, that's acute liver failure. It's rare and it's caused by rapid decline, it's characterized by a rapid decline in hepatic function. So we're talking days and weeks from someone to be completely healthy to a person with acute liver failure. They may present with jaundice, or they may present with a coagulopathy, or also sometimes hepatic encephalopathy. So they might be really confused. They might have strange bodily movements as well, which is all part of the picture. And this is particularly something that you really should look out for, especially if the person previously or has a past medical history of other liver diseases, such as alcoholic liver disease. And if they get Hep A, Hep B, or D, or E on top of it, it can really cause them to decline rapidly. So once again, just to reiterate, fulminant hepatitis is related to hepatitis A, B, D, and E. And lastly, talking about chronic hepatitis. So acute hepatitises, namely B, C, and D, can unfortunately stay in the body for more than 6 months, in which they become chronic hepatitis. And if the chronic hepatitis does continue to progress and inflammation occurs, then it can actually lead to cirrhosis and fibrotic changes. And at the end stage, it can also lead to hepatocellular carcinoma, but shall be talking more about that in another episode. So that brings us to the very end of our podcast today. Thank you so much for listening. If you have any questions, feel free to contact us via our Facebook page, or you can email us as well. Facebook page is probably the best way to contact us at this moment in time. That's it from me, Xiao, and
Simran. Thank you for listening.
thank you.